is Meenakshi and I'm one of the mentors at StudyMEDIC, and welcome to the Back to Basics series. So today I'm going to be dealing with the management of labor, which is a very, very important module. And labor ward prioritization is one of the cases which definitely is going to come in the exam, and all of you are going to face that. So we'll be discussing about 3 cases today. And before we go into the cases, it is important that firstly we'll have a bit of brush up regarding what exactly is management of labor. So there's going to be an overlap between labor as well as delivery. So they go hand in hand. And it's very important that you need to understand about the process of labor. So being well versed with the NICE guideline is very, very important. So you need to understand about what a normal labor is, what is an abnormal labor, when do you suspect a delay, when do you diagnose a delay, and what are the rules for primigravida, multigravida, with and without epidural, and what kind of analgesia is given, and when do you offer the continuous electronic fetal monitoring, and how do you monitor. All of this is very, very important, and it's very important that the NICE intrapartum care as well as CTG is one guideline which definitely you have to read about before you go for the exam. And it is important that you need to be having a situation awareness. Let's say, for example, that there is a case of PPH and she's having bleeding. Rather than, telling that we'll be starting her on oxytocics or going about the further management, etc. The first thing is that you need to, secure a cannula, check for her full blood count, check how her blood levels, and check for her consciousness. Okay, the AVPU scale. All of this is very, very important that you need to see, and based on the situation, you're supposed to act. And if it's an emergency, you have to talk as if it is an emergency, and firstly resuscitation followed by the further management. So stabilization of the patient is very, very important. And next one is you have to involve the consultant as well as midwife. And one important rule is that we are at the level of ST5 when it comes to this examination. Although in our real life, we might be doing multiple surgeries, we might be doing even bladder repair sometimes if it's a small print, etc. Or we might be doing hysterectomies and all of that. But here we are at the level of ST5. So escalating it to the consultant, involving the midwife, all of these are very, very important. And you have to involve the team. It's always a team work, and you need to be aware about who exactly is in your team and how you have to go about the cases. Even if it's like a labor case, not necessarily labor ward prioritization, any different case it could be, it's important that you have to involve the consultant wherever required. And sometimes you will have to be talking to the mother or to the partner. One of the cases which I'm going to be discussing about very shortly, and where you're going to be negotiating for an instrumental delivery. So in that cases also, it's important that you have to involve the woman in the care plan. So rather than just telling that this would be, this is going to be the treatment which is going to be given from our side, rather than telling that, firstly know what her preferences are, and you have to involve her, and based on her, what are her wishes and what is going to be right for her, take the consultant opinion as well, and based on that you will be talking regarding the further care. And it's very important that you have to be very sensitive and very empathetic in certain situations, especially like negotiation stations. Okay, sometimes a woman would be asking for a home birth, which is not a suitable option to her. In that case, rather than dismissing what she exactly wants, your agenda should be that she has to understand why is a home birth not suitable to her. Always give both the pros and cons of whichever option she's doing, whichever she's selecting, and doesn't necessarily mean that it would definitely not be an ideal option to her, but that is something that she should realize. So how you're going to negotiate in a very sensitive way forms the crux of that particular station. And sometimes they might be asking for a VBAC as well at home delivery, where you have to negotiate in a very sensitive way, and you need to be honest about whatever are the possible risks, but rather than putting it in a blunt way, it's important that you put it in a very smooth way and have a proper communication. So this would be a majorly about how you're going to communicate, especially for a woman who is in labor. So there are a few case examples which may come from this management of labor module, or sometimes they've already appeared, and these are something that we would have already practiced. So some of them would be like a quick revision today. So there could be induction of labor, where a woman is coming to you for induction, or maybe induction is suitable to her. So you have to explain about the benefits as well as the risks. And then you have got the cesarean section on maternal request, explore why she wants to have a cesarean section, and based on that, you have to explain the further management. Sometimes you can get a post-dated pregnancy, where you're going to explain about what could be the possible risks if she waits, and if she delivers, what could be the possible risks and benefits. All of this needs to be explained to her. And then you have got the breech or the transverse lie, and where you're supposed to explain about the different options which are available to her. That is mainly based upon the fetal weight, as well as it depends upon the gestational age. It depends upon her preferences, everything holistically. You have to take an approach and explain to her. And then we've got the labor ward prioritization, which is of course going to be the station, the mandatory station that everybody has to go through, IUFD, which we'll be discussing today. And then we've got VBAC and preterm labor, as well as premature rupture of membranes, preterm premature rupture of membranes, PPROM, and certain complications like there could be shoulder dystocia, postpartum hemorrhage, uterine rupture, uterine inversion, as well as perineal tear, and also CTG. CTG interpretation is also very, very important, and it can come even as a teaching station, or sometimes it could be a CTG which is present where you're supposed to interpret. So always use the mnemonic of Dr. C. Bravado, and then you can go in a sequence so that you don't miss out on anything. And please make sure that you read about what exactly is a normal CTG, what is a suspicious one, what is a pathological one, and what are the features of white, amber, and red zones in the CTGs. Please make sure that you read the NICE guideline as well. And a few don'ts and do's that you can do in management of labor is, of course, as we have just discussed, to have an empathetic and a sensitive communication rather than dismissing what the patient wants. So you need to excel in your communication. And the most important patient safety is that you need to give proper handover. Like whenever you're taking the labor ward, it's important that where you're going to take, like at what time, and who are you going to transfer this case to? Is there a consultant involvement required? Is a neonatologist opinion required? All of these, the proper handover needs to be done. Suppose sometimes you're in the labor room and you might get a call from the emergency where you're supposed to attend. So you have to say that you would be giving a proper handover to like such and such or whoever is involved, and then you have to go ahead. Okay. And don't be judgmental, or don't be patronizing. Don't impose any kind of decisions on the woman. Your job is to put a platter of options which is more feasible to her, or which is more applicable to her, if I might say, which is suitable to her, and based on that she's going to be taking her call. And it depends upon how you're communicating and how well you are trying to explain about the options to her, and based on that she will be taking ahead. Like for example, let's say that she wishes to have a VBAC, rather than saying directly about a uterine rupture or a scar dehiscence and all of these complications, or IUFD or something like that. It's important that you say that yes, it's an excellent option for vaginal delivery once they've undergone a cesarean section, and it's successful in about 3 in 4 cases. Most of the women, they do deliver, and the recovery also, if you undergo vaginal delivery, it's quicker. You can have early to skin contact, and they can be a quick and an early discharge as well. But sometimes, there could be like certain risks which are associated with a VBAC. Like whatever you talk about this, it's important that you speak about the scar dehiscence and rupture, need for emergency cesarean section, prolonged recovery, asking about future pregnancy plans, and possibility of having placenta previa, crit, and the subsequent pregnancies. All of these would come later. But firstly, if she's choosing some option, talk about the benefits as well. No harm, right? Not necessary that every VBAC would land into uterine rupture. So talk about what could be the pros, and then talk about what could be the limitations of each of these procedures, and then you can go ahead. And when a patient is expressing her concerns, or when she's trying to express something, or when she's giving you some kind of hints, maybe she's just asking you some questions, rather than dismissing that and say, okay, we'll discuss about it later, and then going ahead and asking some of the questions might not be a good approach towards the station. Firstly, listen to her. Don't overlap what she's trying to say. Just listen to what the role player is saying and take your station forward from there. Okay, so that was a bit of introduction about the management of labor. So firstly, I have included a labor ward prioritization. Of course, you get 2 minutes to read the labor board, and what are you supposed to read in the first 2 minutes? So this is the station where it is given that you are an ST5 and you have taken the handover at 8 a.m. And we've got a few cases on the board, and on the team we have ST1 and ST3 and ST4 and 2 senior midwives and consultant who is about 30 minutes away from the hospital. So when the consultant, it shows that he's 30 minutes away from the hospital, you need to see if there is any urgent rooms. You might have to call, and when the intervention is required, right? So you'll have to be informing about the cases beforehand. And then you get 10 minutes to prioritize, and there are the 4 domains on which you're being tested upon. So when you get the first 2 minutes, what are you supposed to do in that labor ward prioritization? Like when you're sitting outside the cubicle, right? The first thing is that you have to see at what time you're taking the handover. Okay. And second thing is who is in your team. Thirdly, you have to see about any specific instructions regarding the NICU facilities, or whether there is any consultant availability. If they have given, like as in this scenario, I've given that the consultant is about 30 minutes away. And sometimes they would be giving you that the NICU will not be able to take up cases like after under 32 weeks or under 34 weeks. They will be giving you some kind of instructions, or sometimes they'll be telling that neonatologist is not available. It depends, okay, each case to case. So you need to read those instructions very, very carefully. Supposingly there is a case of a preterm labor, let's say, and she's not into very advanced labor, but she's set into labor, suspected preterm labor, and she's at about 32 weeks. You can talk about the in utero transfer when you know in the instruction that the NICU facilities are not there, because she might deliver, right? So you need to speak about that as well, and read the domains. That is very important, that firstly read on which you're being tested upon. And then you need to allocate the team members, okay? Allocation is mandatory. Even though you tell everything about placenta previa, how beautiful you carve your answer also, if you do not say that it is yourself who's going to see the case, that it is an urgent room, then you might be marked down on that. So it is important that you have to allot the cases, okay? So first, always whenever you see the board, see whoever you're going to send, what is the case. You summarize the case as is bar, and then you have to be telling who is going there and what is the urgency of that, okay? Try and decode the urgent rooms first. You can go like room wise, or you can do urgent rooms followed by the remaining rooms. But when you go room wise, sometimes there is a possibility that, at the last also there could have been an urgent room which you might miss out on. And nowadays there are also these evolving scenarios. Evolving meaning sometimes as you keep speaking itself, the examiner would give you the findings that, okay, this case has got this and this, and this case has got this and this. So how are you going to perform? Let's say, for example, you just see that a case of gestational hypertension has come for an elective LSCS at 38 weeks of gestation, right? And then you think that it's a routine case, and you might send in your junior. And when you say that this is a routine case and I would want to send my ST1 to take a proper history and check her blood pressure, meanwhile the examiner says that she's having a blood pressure of 180 by 120, then what are you going to do? It becomes an urgent, right? Then you have to say that I want to immediately attend the case, and then would want to have a check for the blood pressure once again, and then start on the intravenous antihypertensives, give intravenous magnesium sulfate, check for her impending signs, check for the fetal viability. You need to speak about all of this. So this is just one example that I'm giving you. It is possible that any non-urgent could become an urgent, or maybe it might appear like an urgent room for you. Let's say, for example, they're giving you that she's got some bleeding disorder, and now that, she's just delivered. So you might be thinking that she would bleed a lot. And then they say that there is no much bleeding, the uterus is well contracted, and also per vaginum, there is no bleeding at all. So it could be either ways. Urgent could become a routine could become an urgent, okay? And of course, you need to speak about ruling out the allergies, ruling out Jehovah's Witness. That is very, very important patient safety point, which has to be done for each room separately. Okay, and there sometimes we also get questions as in which person should be sent to which room, or who would handle what kind of cases. So for if there is any labor case, it's important that you can send in the midwife. Okay, a midwife can handle all the labor cases, and she'll be also able to suture up to second degree perineal tear. Of course, if it is third or fourth, it is you or the consultant. You under the supervision of consultant would be repairing the tear. Okay, but remaining cases like in terms of taking observations, checking for the CTG, monitoring the labor progression, all of this can be handled by the midwife. And then next, if you've got like a lot of juniors with you, as you read in the first 2 minutes, like which could be routine. Forget about the evolving scenarios. The basic crux, like which could be routine or which could be semi-urgent, right? So suppose there is like 3 different cases which is there, okay? And in one case you're already going, then you can see that, as you can also see that there is a case of a placenta previa on the labor board. I would want to send in my ST4, because ST4 means he's just like a junior to you, he or she, anybody, and they could be better at tackling a PPH as compared to that of ST1, right? So you can ask your ST4 there. And if there is any like elective cases which is there, or maybe there could be an IUFD where initial debriefing is required, anything of that sort, or maybe a post-operative case, you can send in like ST1, 2, 3. Okay, based upon the scenario, you can just allocate to them accordingly. Okay, and you always prioritize as urgent, semi-urgent, as well as routine. And few stations could be evolving, few is may not be evolving. And allocation of team members, as I told you, is very important. Otherwise, it could be marked down on that. And involve the MDT, like informing the OT, the anesthetist, neonatologist. Okay, this is very, very important, and which students might sometimes forget about mentioning the pediatrician or the neonatologist to all the labor cases, to all the antenatal cases. In the MDT, please make sure that you have to involve the pediatrician. And anesthetist as well as consultant, as discussed previously, and taking the consent if you want to perform any kind of procedure, or if you're performing an instrumental delivery, let's say, for example, like taking consent in such cases is important. If you have to shift to the OT, okay, you have to use certain buzzwords like, I would check that the WHO surgical safety checklist is being fulfilled, and if there is any clinical governance, okay, let's say if there is a perineal tear or there is a PPH, in such cases you'll have to be raising an incident reporting, so you need to discuss about that as well. And always use is per format, like for example, if you're telling regarding a case, you have to summarize like the urgency needs to come first, okay, rather than telling this she was this much dilated and this happened and that happened, rather than telling first the urgency should come first when you're talking to the examiner. Let's say, for example, this is the labor ward which I have prepared, so therefore I'm not going to be like reading it through again, and we'll be just revealing the key and how you have to decode it, okay. And because I'm already aware of the stations, I'll be able to read it in less than 2 minutes, like the introduction as well as this. But of course, when you're doing it for the first time, definitely 2 minutes are required. And you can also take out time from the 10 minutes that is being given to you. Like once you go in, you can just read the papers that are being pasted, and you can read through that, and your time would be cut from the 10 minutes, okay. So for example, as you can see here that, she is a primary 29-year-old and she's at 39 weeks of gestation who has been in labor, okay. She was initially 2 centimeters, then she becomes 6 centimeters. Now she's fully dilated with bro presentation, okay. So when you know that it's a bro presentation, that means that the mechanism of labor is not possible, right? So when you're summarizing the case, you can say that I'd like to go to room number 1. This is an urgent case. I would myself go and review the case, and this is a bro presentation, okay. So I'd like to inform the consultant, secure the IV cannula, debrief the woman that there is a need for emergency cesarean section, inform the anesthetist as well as the pediatrician, and securing the IV cannula, and grouping and saving, ruling out allergies, ensuring WHO checklist, and then patient would be shifted to the OT, okay. And sometimes as you keep talking also, they might just cut it on and they would go to the next room, which means that they're aware that you are already aware about that room, so they might take you to the next room as well, so be prepared for that also. And then post-operative, like need for HDU and VT prophylaxis, antibiotic analgesics. Of course, in the 10 minutes, it is not possible to cover all of the points, but I'm just trying to give you an example over here. And the next is a 28-year-old primary, 34 weeks of gestation, who's got a known case of placenta previa. She's having bleeding per vagina. So you can say that the next urgent room is room number 2. So once I settle down the first room, okay, as I know that the consultant is 30 minutes away, I'd like to, inform my consultant that there are, as I can see, there are at least 3 urgent rooms. So firstly, I want to inform my consultant regarding the cases, so that, meanwhile, as I can make my arrangements, my consultant can arrive. Okay, you have to tell that. And then when you see this, like there is a known case of placenta previa. Okay, so just say that, a 28-year-old, like in the room number 2 is again an urgent case where she's preterm with known case of placenta previa. Okay, may I get the examination findings? You can say sometimes they will tell you that there is only spotting or there is nothing much. Sometimes there could be an active bleeding as well. That cases it becomes an urgent room, right? So firstly, assessing the amount of bleeding, know about the fetal well-being, because normally when there is urgent rooms, usually students tend to forget about the pediatrician as well as regarding the fetal well-being, about the CTG if it is required, or maybe even checking for the fetal heart rate. So these are the 2 things that you should not forget about. Okay, securing the cannula, group and save. Blood grouping is very, very important. Rule out the Jehovah's Witness as well. Okay, and if there is no bleeding, yes, you can go for conservative management. Covering the steroids is again very, very important. But in case if it is like an acute bleed, then definitely she would be requiring an emergency cesarean section. After you take the entire the team decision, and ask also whether the NICU cot availability would be there or not, is whether it's available or not. And next one is going to be like a para one who has already delivered and she's got a 3rd-degree perineal tear. So this can be semi-urgent because they've given nothing, but of course it could become urgent when they tell you that she's got bleeding. Send in your midwife initially to go and assess for the tear once again, and do an abdominal examination, check her observations, see whether the uterus is well contracted or not, and then debrief the woman that the complication has happened, and ensure that she's got proper analgesia. Okay, you can give Entonox. Initially, you can offer the inhalation analgesia initially while you're examining. Later, you can give proper regional analgesia whenever the repair is required. Shifting to the OT is again very, very important. And you can place a vaginal pack as well, just in case if she's got any bleeding, and then you can shift to the OT, which is going to be prepared by the consultant or by you under the supervision. And then you speak about the clinical governance parts like the incident reporting and documentation, duty of candor, debriefing, and of course you need to explain about the post-repair, the care, the perineal care, as well as regarding the physiotherapy. And the next one is about 36-year-old who is a primee who was presented at 39 weeks. She's been transferred from home at 5 a.m. in view of slow progress. Okay, so already it has been given to you. So you can see that what is the slow progress all about. Okay, do a pervaginal examination once again to check for the findings, see whether the uterus is contracting well or not, any malposition that needs to be seen, and group and safe, and also, debrief the woman that, that there is a little like slow progress. Once again, of course, she would have already been told. That's the reason she has been shifted here. So as you keep settling the urgent rooms, you can send in your midwife to this, and your midwife, because she's a labor case, right? So your midwife will be able to manage the initial management and ask a midwife to check for the fetal weight as well as check for the recent scan to see, okay, to rule out just any malposition. And then you've got like a 35-year-old who is at 38 weeks of gestation, who's come with decreased fetal movements, diagnosed as IUFD. So you can just say that, the room number 5 is semi-urgent case where, it's a case of IUFD and with rhesus negative blood group. So you can send in your junior initially to just take the history. Okay, take the history initially, have an empathetic approach. Okay, take a detailed history to understand what was the possible cause, like why there has been an IUFD. Sending for investigations and grouping and saving his involvement is important. And then once you settle the urgent rooms, you have to say that I would want to apologize for the delay, and then I would want to review the case by myself and inform the consultant regarding this. And you have to discuss about the management plan. It depends upon whether she's getting pain or not. If she wants to go home, giving the warning signs and asking her to come back. Discuss about the anti-D as well. And next one is about the 28-weeker who is presented with leaking per vaginum, and her CTG is normal, right? So here the CTG is normal, which is reassuring, which is called leak. Okay, so you can send in your junior first, ask to see a detailed history if there was any kind of risk factors, and when was she last examined, and steroids, antibiotics, as well as GBS status also needs to be seen. First important is to see whether the antibiotic has been started to her or not, whether the steroid coverage has been given to her or not. Next is room number 7, who is a 32-year-old, and she's a para 1. She was delivered yesterday, and she had a PPH, which is approximately 1.8 liters, right? So it's a semi-urgent case, could be routine also, right? And send in your junior to check her observations to see whether the uterus is contracted well or not, what was the reason for PPH, okay? And then you need to, check on the baby as well, like how the baby is doing. And since she's post-operative, check for her IO chart, the input-output chart, and see whether she's able to ambulate well, and if she's able to eat or drink anything, just go about her well-being. You raise an incident report because the PPH is more than 1.5 liters, and then you have to debrief as well as document everything in the notes. And the next one is a 33-year-old who has come at 38 weeks of gestation. She is under VBAC trial, who's 5 centimeters dilated at 3 a.m. and now she's got hematuria. So you know that there is a possibility of rupture here. So therefore you have to involve the consultant, anesthetist, and pediatrician, secure the cannula, group and safe, counsel her, and shift her for the emergency LSCs. So in the 2 minutes, whenever you're reading this, you have to write down in your paper that this is going to be urgent. See, irrespective of whether it's evolving or not, as you can see the board, you know that, bro, it is an urgent case. Placenta previa, that is an urgent case. And then next one is a VBAC trial. These are urgent cases. Okay, possibility is that these are urgent cases right now. And then maybe if you can look into rest, this 3rd-degree perineal tear could be an urgent case. Maybe that can become a PPH as well. And then this one is about leaking PV. Could be maybe chorioamnionitis as well, sepsis maybe. So that also can be a possibility. So yeah, it can be evolving. You don't know, but initially, once you look at the board where there is a possibility of being like a frank urgency, that rooms are something that you need to prioritize and you need to speak about it first. Let's look at the domains. It's important that you get the notes, pactogram, CTG, and metanol observation, so that you get a clear picture about the patient, and you should be able to describe a clear action plan made, which is based on the discussion with the patient. So whenever I have included that when you're shifting for OT, counsel the woman, debrief the woman, need for say explain to the woman. Okay, so you need to involve the woman in her care plan rather than taking a monotonous decisions only by taking lateral decisions only from our side. It's important that you involve them as well, and to maintain the patient dignity at all times. Always, like whenever you want to examine, say that you would be doing it with a chaperone, and you need to be aware about the patient safety in the labor, and understanding the risk management and clinical governance parts. Okay, that is very, very important. And you need to be very well versed with your guidelines, the NICE guidelines especially, and you should be able to think and work under pressure. So because reading that in the first 2 minutes could be a bit challenging, but it's definitely doable. And once you sit inside, it becomes very easy, because it's going to be like a one-on-one conversation with somebody of the same position who's sitting opposite you, the examiner. You're going to talk to them just like how you were discussing cases with your senior. It's going to be very simple as that, and there's nothing that you need to panic about the labor ward. And you need to be understanding about who all needs to operate in that particular case, and who all you need to involve. Involving the team is very, very important. And knowledge about the intrapartum care, and communication with colleagues is about the handover, like how you're prioritizing the cases, and how you delegate the cases appropriately. Okay, and then doing a teamwork, and providing the amount of details to ensure that there is a clear and easily understood. So when you're telling that, when you're summarizing the case in the first 2 minutes, you already know like what are the room number one is bro in labor, then such and such room is like placenta previa with acute bleeding, PV with antepartum hemorrhage, and then you can see that there is a VBAC trial with hematuria, possibly a uterine rupture. Summarize in that way. The urgency should come first. Okay, and you should understand when you have to limit your level of expertise, and when you have to call in your senior is something that you need to be looking into. Okay, so that was a brief about the labor ward prioritization. And the next station which I have put up is and that this is also SPT, where you've got like 4 domains, and you're going to be seeing a 34-year-old primey who's in spontaneous labor, and history is already given that she's low risk and everything has been uneventful till now. She's got no significant medical surgical history, which means that you are left with very little history that you need to ask about. So don't repeat whatever is already given to you. She's already progressed well, and she is under epidural. Okay, so this is something that you need to highlight, that she is epidural and primary. That means you can allow 3 hours for her. And she's in second stage since 2.5 hours and very tired to push. When she's having tiredness, okay, fatigability, you need to call for an instrumental delivery, right? And the rest of the findings are given, which is almost at +3. So therefore, you need to speak about the forceps versus like vacuum. And sometimes they would be having some preferences during the antenatal period as well. They would be giving you sometimes the instruction that, please take consent for the forceps delivery or something. Okay, so as you know this in the first 2 minutes, you know that your history expansion is going to be very, very limited, like the angle in which you're going to take history. Just you need to ask is that she is in labor. Okay, so you have to just ask that as if you're in labor ward, right? So hello, I'm Dr. Meenakshi, one of the doctors on the labor ward today, and am I speaking to like Sarah? Okay, how would you like me to call you? I see that you've been in labor and you've been doing extremely well until now. How are you coping with the pain? Okay, just like that. Okay, keep it more conversational and keep it more engaging. And then you can just ask like, is there any other issues that you're currently facing? And have you named a new baby? Okay, and when she says some kind of name, or if she's not yet thought about it, then you can just say, are you able to feel the kicks properly? Of course, when the uterus is contracted well, you might not be able to feel it, appreciate it very well, but just as a matter of concern, and just like you're building rapport with her, you're going to ask her. Okay, and then you can just say that, I would also want to go through your notes with your permission. And have you got allergies to any medications? Because allergy is not mentioned over here, right? And the blood group is also not mentioned over here. You can just ask like, have you got any reservations for the blood transfusions? Okay, and who is there along with you today? And then maybe we can call in your partner as well to have a discussion about you. Okay, then assure her that until then you have been doing really, really well, and I see that you're coping up with the pain very well, and I also see that you're under epidural, and I can also see that that you're unable to push, and you're quite tired, and we've got some solution for this. For the present, I want to tell you that if just name the baby, just address by the baby's name, that your baby is doing absolutely fine, and your baby's heart rate is also completely normal, and there is no worries about that. But what we're really concerned about is that you're being tired and you're unable to push, and it's important that we have to deliver because it's been 2.5 hours, and what are your thoughts about this? And then she'll tell you that I'm not willing for an instrumental delivery or something like that. Then you can just ask like, what are the concerns behind, like, why is she not willing for an instrumental delivery? Is this something that is bothering her, and is it something that is holding her back? Okay, you need to address that concern. Maybe her friend had a bad experience, or maybe she does not herself have a good opinion about that. So try and address about it and say that it's completely understandable where your concerns are coming from. But how you have to negotiate it. Suppose she's saying that they could be tears or something like that. You can say that yes, you're absolutely right. There could be a possibility of tears, but doesn't necessarily mean that it's going to happen with all of the patients. We'll take utmost care, and we'll involve the senior midwives in your care as in to avoid such kind of complications. But sometimes it is possible that there could be such risk, but we will take all the necessary measures as in to prevent that. Okay, you have to acknowledge. Don't say that no, there is not going to be any tear, because you don't know. Sometimes even a woman without risk factors also could have a perineal tear, right? So always acknowledge her concerns. This is what I was saying in the very beginning, that don't dismiss what she wants to express, and try and acknowledge her concerns. And when you acknowledge that in a very sensitive way, she's going to agree to whatever you are telling. Okay, because she knows that now you're a good doctor and you're trying to explain everything to her in an honest way, and then she's going to agree upon that. And then she might be telling that she just wants to have a cesarean section. Then you can say that the head is very much down below, performing a cesarean at this stage could be more trickier and could be more riskier, can cause more damage as expected as compared to that of a cesarean section who we perform on a woman who is not in labor. Okay, that's how you have to counsel, and you go ahead. And if she still wishes to have, then you can say, I'm sorry that we are unable to come onto the same page, and maybe I can call in my consultant, or I will be calling in a senior who you can have a further discussion with. Okay, it only depends upon how you're counseling her. If you're doing it in a very sensitive way, and if you're trying to explain everything, whatever is there, in a very clear and a transparent way, then definitely she's going to agree to you, because these stations are the negotiation stations. So intro and believing, developing rapport with her. And if she's doing like pain, if she's having some pain, it's like, just breathe in, you're doing completely fine, so just breathe in, just relax. Okay, it's like you're comforting her. Okay, and reviewing her notes with permission. And then you have to tell that, whatever we are doing, it's only done in the interest of like her baby's health. Okay, how is she, in general, now if she's got any other concerns that needs to be addressed. And you have to see like why exactly she wishes to go for a cesarean, or what is holding her back from having an instrumental delivery. Ruling out allergies, respecting her wishes is again patient safety, and allowing her to make an important informed choice. And don't push her. Okay, don't impose any kind of decision, it's going to be completely her choice. Okay, and counseling about the forceps and vacuum delivery. Sometimes an instruction would be given to you that you have to counsel for a forceps, and sometimes it would be given that you have to counsel for a vacuum. Station doesn't necessarily mean it could be +3, it can be +2 also. So based on that, you're supposed to tell and counsel about the risks of the second stage cesarean section as well. Okay, so that was one negotiation station, which is very important that you all have to practice. And it's mainly tested upon how you're communicating well with the patient who is in pain. The last and final station for today, which I've included, is about a 33-year-old woman who's come at 36 weeks and diagnosed to have an IUFD. And there are the 4 domains that you're being given upon. And here she is Mrs. Christina, 33-year-old, and she's an investment backer, 36 weeks pregnant, and she's a low risk pregnancy. And she came with decreased perception, and she's asked to get a scan, which is confirmed IUFD. She was told by her midwife about the scan, and she's really upset, and she wants to discuss about the further tests. Okay, so you have to address her further. See, there could be one line which is given like address her concerns, answer to her questions, and formulate further care plan. Okay, there are certain instructions which are given to you, so you have to decode them. See what is exactly asked from the station. Based on that only, you have to process your station. So there are different possibilities to the station. One is that she is not aware of an IUFD, where you're going to disclose to her that it is an IUFD. So it's more of an emotional tangle where she's going to be like crying, and she'll be weeping, and she's going to be upset. So you need to go through, and you need to acknowledge all her emotions, and that's going to be like an emotional roller coaster. So it depends completely upon how you're going to deal with her, rather than saying, may I ask you a few questions, may I ask you a few questions, rather than doing that. Yes, you may ask questions, but firstly acknowledge her, be sensitive. Firstly try and understand news kind, where you give the warning shots and confirming the name, NHS number, offering her support. All of this needs to be done. The second possibility, as in this case, is she's already known that it's an IUFD, so you have to take a history, try and decode like what could be the possible risk factors for her IUFD, and then further you discuss about the further tests, etc. The third possibility is that it's already an IUFD and she's already delivered, and you have to discuss about the postmortem examination and all of that. So that is one possibility. The other possibility, the fourth one, is she's coming to you with the postmortem report, where there could be anything which is positive. And based on that, sometimes, the APLAS could have been positive, and where they came with postmortem and all her blood work and all of that, whichever was sent. And there could have been a possibility of an abruptio placenta or something. They would be giving you with that some kind of report, and they would come to you, and then you have to take that station further. Okay, so always this is more about the communication. Okay, so how sensitive you are, and this communication with patient is extremely important in these stations. Okay, could be a lay examiner also, because you're being tested on communication. So how empathetic you are and how you're trying to understand what she's going through, something that is very important here. Okay, rather than just saying that like, what is your name and how would you like me to call you, and then saying like, can you tell me what exactly has happened, rather than telling that. Open the station with condolences only in such scenarios. Okay, just say that, hello, I'm Dr. Meenakshi, one of the doctors in the clinic today, and whenever you're speaking to her about your interaction, I'm so sorry, I'm really aware, I'm aware of your loss, and I'm so very sorry to be meeting you in this situation. And then just wait and give some pause. Okay, don't ask like, how are you coping or how are you doing right now? Okay, because that might not sound good, because she's already deep down, and when you give a pause, she herself would start emoting, and she'd be very very emotional, and she could be crying, and she'd be weeping, and all of that would happen. So say that, I'm really very sorry to be seeing you in this situation. Okay, and I'm here to discuss about how we can manage you further. Are you comfortable talking to me, or do you want me to reschedule? Are you comfortable? You could just ask like that, and then she'll be telling like, okay, yeah, maybe we can go ahead or something. Only if she's like crying repeatedly and she's weeping, and if you're unable to console her, such you can say about postponing the consultation. But otherwise, it is not required because you've just started the station, and rather, if you postpone it at the very outset, it might not sound very good. Okay, and put an open question regarding her pregnancy, etc., and then she'll be able to tell. Then you can just ask like, since when you were not able to feel your baby, and have you ever had such kind of prior episodes, and were you ever told that you had some high blood pressures or sugars during the pregnancy? May I review your notes? May I review your scans until now? Okay, currently how are you? Like, do you have any pain, any discomfort, or any bleeding? All of that you need to ask. Okay, and excessive itching of palms, again you need to rule out ICP as well. Okay, and you can also say that, I'm so sorry to ask, but have you named your baby? There's no harm, okay, because you're just building communication. And further, if you want to explain about postpartum and all, when you use baby's name also, they would be comfortable listening to all of that. Okay, and ask for blood group because she'll be requiring delivery, so reservations for blood transfusions and remaining, and asking about support at home is again very important in this. And then once she already knows that it's an IUFD, you have to counsel her regarding, offering the admission. That is very important, and telling her that, it is important that we'll have to, kickstart the labor, and we'll have to be, waiting, we have to deliver, because sometimes there is a possibility that there could be certain complications which are expected, like chances of infections, and there could be certain clotting problems as well, a condition which we call as DIC. And if she says that, no, I just want to go home, I want to take my time, then you can say, yes, you can take your time, but please ensure that you come back at the earliest, and because your safety is a priority. And meanwhile, if you feel any kind of discomfort or any bleeding or anything unusual, please get back to us immediately. And I will also give you leaflets on the same, and you can come back to us whenever you have made your mind. But I would recommend you to do it at the earliest. Okay, and if she's willing to go for an expected management, you have to talk about screening for DIC as well. So that is something that you need to look into. And don't always push her to make any kind of decision. If she wants to go home, explain the risks and send her back home. Okay, and because she's lost her baby, so you need to be like very empathetic, and you need to be like consoling her, and you need to understand what she's going through, and tell her, yes, you may go, but when you have to come back is something that you need to guide her. Tell her that it is better that you always come back at the earliest, because also, carrying this pregnancy forward could also be an emotional burden to you. So very sorry once again to be meeting you in this position. Okay, you can say that. And check for her BP as well as urine for proteins as well. That is again one important point. And then you can speak about the expectant versus induction, and what happens if she's waiting, and what happens if she gets delivered. And yeah, sometimes they would be telling you that, you have to send for the investigations, wherein you have to tell that we'll be checking for all your blood sugars, and we'll be checking for the full blood count, okay, the strength of your blood, and certain clotting problems, and all of these investigations also would be sent. We'll be checking for kidney function and all of that you have to say. Okay, and maybe about the postmortem and all, you can just say that, there are other tests as well which we can perform, but it is too early to discuss about, and I don't want to overburden you regarding the same, and certain tests like postmortem, etc., which we'll be discussing in the next appointment. You can tell that way also. At least the examiner knows that you are aware that you have to talk about certain investigations, but because of the time constraint, you're unable to talk. Okay, that is something that would be conveyed to that. Okay, so that was in short about the management of labor and 3 important stations. I hope you found this video useful, and if you've got any doubts, let us know in the comments below, and please do subscribe to our channel, and happy studying.